Hello and welcome to my channel. This is a course called the MBBS FlashDash, which is mainly aimed at final year medical students who need a quick revision before their finals. In this video, I will be continuing part 2 of the Vascular Series. Do check out the links below in the description if you want the slides from this video on my website and also flashcards, which I've uploaded on Pinterest. Let's begin. In this video, we will be covering ulcers, carotid artery stenosis, Raynauds phenomenon, and Buerger's disease. The first one, ulcers. So this is just an overview about several types of ulcers. The first one, arterial ulcers. It's caused by ischemia, secondary to an inadequate blood supply. They're usually smaller, deeper, have well-defined borders, punched out appearance, occurs peripherally, usually on the toes, and there's reduced bleeding, but it's painful. Venous ulcers, it's caused by impaired drainage. So the arterial ulcers, lack of blood supply. Venous ulcers, there's pooling of blood and usually impaired drainage. So they are larger, more superficial, irregular, gently sloping borders. It's usually affecting the gaiter areas. They're less painful than arterial ulcers, but there are other signs of chronic venous insufficiency. Diabetic foot ulcers, more common in patients with diabetic neuropathy. So diabetic neuropathy is when there are lack of sensation to that particular area. So people with usually uncontrolled diabetes mellitus, they tend to develop diabetic neuropathy, and because there is lack of sensation, usually when there are cut, injuries, or wounds, the patients are not able to actually see it or realize it, hence progression or constant trauma to that area will form ulcer. So there's also less loss of sensation in their feet, and an important complication to take note of here would be osteomyelitis. Then there's pressure ulcers, and it occurs in patients with reduced mobility, where prolonged pressure on that particular area causes the skin to break down. It occurs due to a combination of reduced blood supply and localized ischemia, reduced lymph drainage, and there's abnormal changes. So the first one, arterial ulcers. It's caused by ischemia secondary to an inadequate blood supply. Clinical features, the ulcer may be on the toes, feet, lateral malleolus or tibia that is irregular, deep, and necrotic. So it's important to denote where is the location of the ulcers. So in arterial ulcers, it is usually on the lateral side, whereas in venous ulcers, it's usually on the medial side. So there may be unilateral or absent or weak pulses on the affected side. It is very painful, more painful than venous ulcers, and if you were to check the capillary refill time, it is prolonged. So the causes would be peripheral arterial disease. Some risk factor to take note would be smoking, uncontrolled or long-standing hypertension, uncontrolled or chronic diabetes mellitus. The investigation you would perform here would be ABPI, ankle brachial pressure index, whereby you take the systolic BP of the ankle and you divide it by the systolic BP of the arm. The treatment, you would consider surgical revascularization because there is lack of blood flow supplied to that area, and eventually it may actually worsen, or the patient may suddenly have acute limb ischemia or critical limb ischemia. Next is venous ulcers. It is caused by the impaired drainage and pooling of blood in the legs. Clinical features, ulcer at the medial distal leg. So take note of the location, medial, whereas in arterial ulcers, it is lateral. There would be hemosiderin deposits, granulation tissue. It can be painful because there is no loss of sensation, but it's less painful than the arterial ulcers. So all these presentations are seen in chronic venous insufficiency and varicose veins, which I've talked about more in depth in the part 1 of this vascular series, so do check it out after this video. Some causes: varicose veins, deep vein thrombosis, pregnancy, or increased weight. Treatment would be compression stockings to aid in the backflow of the blood to the heart, some dressing to keep the area clean, to prevent infection, leg elevation, and also encourage mild exercise, because the contraction of muscle will aid in the movement of the blood back to the heart. So as you can see here, once you see, let's say in exam, in MCQs question pops up, or maybe even a modified long case, let's say modified essay questions, let's say they told you the area medial malleolus, it is painful and there is hemosiderin deposit, pick venous ulcer, even if the patient is diabetic, because the part that the patient is diabetic is just to confuse you, but you've seen that it's on the medial side, there's hemosiderin deposit, there's venous ulcer, it is painful, so it is venous ulcer. Now if a patient is diabetic, they tend to have diabetic neuropathy, which can contribute to the ulcer formation because they're not able to feel as their nerves have been damaged. However, in this case, there are hemosiderin deposit, and the patient also says it's painful. And hemosiderin deposit and the location of the ulcer points to the type of the ulcer, which over here it's medial. The fact that it is painful meaning there is sensation, so it crosses out the neuropathic ulcer. Next is neuropathic ulcers. So the ulcer may be on the toe or plantar surface of the foot. It is deep and punched out. It is surrounded by callus, and there is reduced sensation. So the most common cause of this would be diabetes mellitus, and also pressure points on the bottom of the feet. So the treatment would be to remove pressure, to manage the diabetes mellitus, especially if it's uncontrolled, and to advise diabetic foot care. Moving on is carotid artery stenosis. It refers to the narrowing of the carotid arteries in the neck, usually secondary to atherosclerosis, as you can see over here. So the plaques build up in the carotid arteries over time, and this reduces the diameter of the lumen, so the amount of blood that's able to flow through has been reduced. There is a risk of parts of the plaque breaking up, which is over here. It may break away and become embolus, traveling to the brain, and may cause an embolic stroke. It is usually asymptomatic and diagnosed after transient ischemic attack or stroke. So some clinical features: there may be loss of consciousness suddenly. The patient may have a transient ischemic attack or worse, stroke. The initial test would be duplex ultrasound, and the gold standard would be a CT or MR angiography. Now treatment. The first line treatment would be carotid endarterectomy. It is first line for most patients requiring surgical intervention. You may also consider angioplasty or stenting. This depends on the degree of the occlusion. Some conservative management to take note would be healthy diet and exercise, stop smoking if the patient is smoking, management of other comorbidities such as hypertension or diabetes, especially if it's uncontrolled. Start the patients on antiplatelet medications such as aspirin, clopidogrel, ticagrelor, and also lipid-lowering medication, atorvastatin. Raynauds phenomenon. It is the paroxysmal vasospastic and subsequent vasodilation affecting peripheral arterials, usually seen on the hands, like over here. So clinical features, there will be pallor, numbness or pain, followed by cyanosis of the distal portion of the digits. As you can see here, there's cyanosis. Now, if the person is less than 30 years old and it's less severe, it's primary Raynauds phenomenon. If the patient is more than 30 years old with severe pain and ulceration and gangrene, worst possible case scenario, it's secondary. Treatment of it would be to avoid the cold, because cold is usually what triggers it. It's, vasospasm, basically the blood vessel of that area just have a spasm, like it suddenly constricts, and there's inadequate, less blood flow flowing through that area. Hence, you will see, this part is red, and this part over here, there's pallor. Smoking cessation, if the patient is smoking, and also calcium channel blockers, nifedipine. Buerger's disease, another word for it would be thromboangiitis obliterans. They're the same. It is an inflammatory condition that causes thrombus formation of small and medium-sized arteries in the distal arterial system, usually affecting the hands and feet, more so the feet. Typically affects men aged 25 to 35 years old and has very strong association with smoking. Usually people who are chain smokers, and they tend to apply lots of pressure on their feet or their static. That's what I noticed last time when I was a student. I actually clerked this patient having a Buerger's disease, and yeah, he was 30. A little bit about him, he was 30 years old. He was very young actually, but he smoked a lot, and he used to wear these tight-fitting shoes, and he was a lorry driver, and he said he noticed that started to have this pain that comes and go, and eventually he noticed one day that his toe just turned black, and that's when he actually came into the hospital. So some clinical feature to take note over here. There is extreme ischemia. So first, they may have intermittent claudication. So intermittent claudication, pain that comes and goes, and the pain usually comes with exertion and disappears with rest. And then eventually, they may have resting pain and also formation of ulcers, usually ischemic ulcers, and they will be gangrenous, black color. Superficial thrombophlebitis, they may even have Raynauds phenomenon. Claudication pain, as I mentioned earlier, in the legs or the hands. Discoloration of the affected limb, skin ulceration and digital gangrene. And as I mentioned earlier, it's strongly associated with smoking. So the treatment over here would be iloprost. It's a prostacyclin analog that dilates blood vessel and smoking cessation. But in the case where it's not possible to save the limb, usually there will be amputation. Like the patient I was talking about earlier, it was too late to save his limb actually, and the ulcer had started to spread, and first it started at the toe. It was just a small area, and then it eventually started to spread and covered all his toes and spread upwards. And I didn't follow up on him, but he did told me that time that they were going to amputate his limb. Alright, so if you've reached this part of this video, thank you so much for watching. Please hit the subscribe button and press the notification bell so you don't miss out on any new videos. I post videos weekly. See you in the next one.